All right. So a very good evening, everyone. So I welcome you all to this particular the hematology emergency session part 2. So yesterday, like we have discussed some of the hematological emergencies. That is one of the very important hematological emergencies that we have discussed yesterday was the transfusion reactions. That was one of the very important session. And those who did not watch the yesterday session, please watch that. That will be definitely useful for your routine clinical practice and as well as even for the entrance exams. I have discussed some of the questions as well. Now, today will be the hematology session, emergency session part 2, wherein I'll be discussing mainly the disseminated intravascular coagulation. I'll discuss hyperviscosity syndromes, and then I will also show you some of the clinical scenarios of the hematological emergencies. Right. So before starting the session, let me just start the session with a very important positive note. Now, because as the exam is approaching nearby, the exam is on March 5th. So many of the students are under the fear of not able to crack the exam, and many of the students do give up at this particular point of time. So please, you have to focus on your goals, not on your fear. And it is not that easy to experience, but we need to go through this particular phase of life. So please focus on your goals and not on your fear, right? And like if you take this particular fear of failure is normal, but that fear should never stop you from achieving your goals. That is a very important thing that you need to keep in your mind. See, whenever the obstacles arise during our preparation, what you need to do is you need to change your direction to reach your goal, but you should not change your decision to get there. Okay, so you should not change the decision of achieving the goal itself. Whenever the obstacles arise, you need to change your direction. Okay, and lastly, don't let the fear of failure stop you, right? You have to remember that the world needs you, right? You are the doctor, definitely the world will be requiring you, so the world needs you, your greatness. So that is what you have to keep in your mind. So don't let the fear of failure stop you in achieving your goal. Okay. So having said this positive note, now let me tell you what all the points we'll be discussing now. So I'll be discussing this disseminated intravascular coagulation, hyperviscosity syndromes, and clinical scenarios of the hematological emergencies. All that we'll be discussing today, right? Now, if you see the question here, okay. So you see the first important, the hematological emergency, right? Go through the clinical scenario and try to answer this. I'll give you the explanation of each and every option. Now, having made a new diagnosis of polycythemia rubra vera. Polycythemia rubra vera is what? It is one of the hyperviscosity syndromes. You are consulting with the patient regarding the prognosis and complications of the condition. Right, so you're explaining prognosis and complications of your polycythemia rubra vera. He has read the information booklet and wishes to know about common vascular complication of this particular condition, polycythemia rubra vera. Which of the following is the most common vascular complication secondary to polycythemia rubra vera? Right, the first option is Budd-Chiari syndrome, ischemic stroke, livedo reticularis, mesenteric vein thrombosis, pulmonary embolism. Yeah, the first part is uploaded in the YouTube, right? So that is there in the yesterday's session, okay? Right, so what do you think is the most common vascular complication secondary to polycythemia rubra vera? Now, if you take all these conditions, right? All these conditions are associated with polycythemia rubra vera, but the most common is the ischemic stroke, right? The most common is the ischemic stroke. Now, if you take this polycythemia rubra vera, what exactly is this? This is one of the neoplasm, right? This is one of the neoplasm, and this particular polycythemia rubra vera, which is a neoplasm, it arises in multipotent myeloid stem cell, right? It arises in multipotent myeloid stem cell. That is characterized by increased marrow production of the RBC, right? and that is characterized by increased marrow production of the granulocytes, and that is characterized by increased marrow production of the megakaryocytic elements. So accordingly, this will lead to what? Erythrocytosis, that is polycythemia. There is increased granulocyte production, so there will be granulocytosis, and there will be also thrombocytosis in the peripheral blood, right? So it is an abnormal proliferation of all the hematopoietic stem cells. Now accordingly, you have the manifestations. Because of increase in erythroid elements, what will be the clinical features? Due to increase in granulocytic elements, what will be the features? And due to increase in megakaryocytic elements, what will be the features? So all that, let me discuss now. So now, because of the increase in the erythroid elements, that is your RBC, which is nothing but your polycythemia. So what can happen is there will be increase in the blood viscosity. Once there is increase in the blood viscosity, so what is happening here? There is increase in the quantity of your RBC. Now all these particular RBCs, if they don't get adequate oxygen, that will result in cyanosis. When does this particular cyanosis occur? When the quantity of reduced hemoglobin is more than 5 grams per deciliter, that is the point when there can be cyanosis. Now there is increased RBC, so there is increased hemoglobin. Accordingly, if the oxygen is not received to this particular increased RBC, that will result in cyanosis. And because of hyperviscosity, there is decreased movement of the blood. That will result in decreased cerebral perfusion, and because of which you will have neurological symptoms like headache, dizziness, visual disturbances, vertigo and tinnitus. And there will be features of hypersplenism, that is splenomegaly, and there can be also the systolic hypertension. So these are the features of increase in the RBC elements. Now the next important thing that you need to know is increase in the granulocytic elements. Now within the granulocytic elements, which particular element is elevated mostly is the basophils. Whenever the basophil is elevated, within the basophil you have a chemical mediator which is secreted from that basophil, and that is nothing but the histamine. Now this particular histamine is the one which is responsible for intense pruritus, that is severe itching. And this particular histamine will also stimulate the parietal cells which are present within the stomach. And once the parietal cells within the stomach are stimulated, there is excessive HCl production, and that will result in the peptic ulceration. And there will be also release of intrinsic factor. And because of excessive release of intrinsic factor, there is increase in transcobalamin 1 and 3. This causes increase in vitamin B12 binding capacity. So these will be the manifestations because of increase in the granulocytic element. Now, what will be the manifestations due to increase in the megakaryocytic elements? That is nothing but your platelets, and that will result in increase in the thrombosis, right? And this particular thrombosis can be within the deep veins causing deep vein thrombosis, can be in the coronary arteries causing myocardial infarction, can be in the cerebral vasculature causing stroke, that is the most common thrombotic event. It can be in the hepatic vein causing Budd-Chiari syndrome. It can be even within the portal vein causing portal hypertension. Now, these individuals will also have the bleeding risk as well. So these are the manifestations of the polycythemia vera. Now, in these patients with polycythemia vera, now tell me what will be the investigations. All of the following are seen in polycythemia rubra vera except increased vitamin B12 binding capacity, decreased leukocyte alkaline phosphatase score, leukocytosis, increased platelets. So what do you think is the correct statement? Sorry, in the sense, which is the except? Yes, any one of you please. Now, so if you take the answer here, it is decreased LAP score. Please remember, in patients with polycythemia rubra vera, there will be increase in your leukocyte alkaline phosphatase score, right? And this particular increase in your LAP score is not just seen only in polycythemia rubra vera, right? This particular increase in your, so what will happen in polycythemia rubra vera? The LAP score increases. Now, this particular increase in your LAP score, it is also seen in the other conditions like leukemoid reaction, also seen in case of the aplastic anemia, right? Also seen in case of the aplastic anemia. Next, multiple myeloma. Next, Hodgkin's lymphoma. These are all the conditions where there is increased leukocyte alkaline phosphatase score. So, and what about the other options? There will be increase in your vitamin B12 binding capacity. Why is that increase in vitamin B12 binding capacity will be there? That is because of increase in your transcobalamin 1 and 3, which is being released from your parietal cells. Okay. And leukocytosis, definitely there will be increase in your leukocyte count, and this particular normal leukocyte count is around 4 to 11,000 per cubic millimeter, and here the leukocyte count will be around 15 to 50,000 cells per cubic millimeter. That will be the elevation of your leukocytes. Then coming to your platelets. Now what will happen to the platelet count? The normal platelet count is around 1.5 to 4 lakhs per cubic millimeter, and here the platelet count, it will be more than 10 lakhs per cubic millimeter. That is what will happen in patients with the polycythemia vera. And not only that, what will happen to your RBC count? If you take RBC count, that will be more than 6 million per cubic millimeter. That will be the RBC count in patients with the polycythemia rubra vera, right? And not only that, even your hemoglobin, what will happen to the hemoglobin level? That also increases. And how much will be that? More than 18 grams percentage. And what will happen to your hematocrit? Hematocrit also increases, and that will be more than 51%. So, and even the blood viscosity increases, but what happens to your ESR? The ESR will be reduced. This is a very important point you should remember. So, this is about the investigation or workup in patients with your polycythemia rubra vera, right? But your LAP score will not decrease. The LAP score will increase. Now, I'll just quickly show you one more important question. Right, you see this question. A 59-year-old male came with hemoglobin of 18 grams per deciliter on 3 occasions. The resident doctor wants to exclude polycythemia vera. Which of the following is the most relevant investigation? Hematocrit, total leukocyte count, red cell mass, reticulocyte count. Right, this is a very, very important question, and let me see how many of you can answer. Right, now let me tell you, the correct answer here will be, right, so the correct answer here will be red cell mass. It is not your hematocrit or the total leukocyte count. Now you see here, whenever confirmed with increased hemoglobin or hematocrit, so you are very much clear that the patient is having increased hemoglobin. Okay, so when confirmed with increased hemoglobin or hematocrit level, the first step should be to establish the presence of increased red cell mass. Right, you should establish the presence of increased red cell mass to consider it as polycythemia rubra vera. Why? That is mainly to distinguish absolute erythrocytosis. Right, that is mainly to distinguish absolute erythrocytosis from relative erythrocytosis. Okay, why? Because if you take your absolute erythrocytosis, definitely the red cell mass will be elevated, but in case of relative erythrocytosis, there will be increase in your hematocrit, and this increase in your hematocrit is due to decrease in the plasma volume. Okay, so to differentiate absolute from relative erythrocytosis, what you need to look for is the red cell mass. And once the presence of absolute erythrocytosis has been established, its cause must be determined. What is the cause of this polycythemia rubra vera must be determined. So the answer is the red cell mass. It is not your hematocrit. So this is one of the very important area where you people can do the mistake. Now, once you confirm that the patient is having polycythemia rubra vera, what is one of the very important treatment? The very important treatment will be phlebotomy for your polycythemia rubra vera, right? It is one form of treatment which often may be combined with the other therapies as well, right? And see, the removal of blood from the body, it induces the iron deficiency, thereby decreasing the hemoglobin, decreasing the hematocrit level and reducing the risk of the blood clots. So that is the advantage of the phlebotomy. So that will reduce the hematocrit, hemoglobin, and reduces the risk of the blood clots. Okay. And now whenever you are doing phlebotomy, what should be your goal of your hematocrit? The goal of the hematocrit, what is hematocrit? That is RBC percentage. So your hematocrit should be less than 45 in males, and the goal of your phlebotomy should be less than 42 in females. The hematocrit should be less than 42 in females, and there is increased risk of thrombosis. So that is the reason why along with phlebotomy you also need to give aspirin. Right, you also need to give aspirin 75 to 81 milligrams daily. It is often prescribed. Right, now apart from this phlebotomy and as well as aspirin, now for suppose in certain scenario you are unable to do phlebotomy, right, in certain scenarios you are unable to do phlebotomy, then in such case, like, what you need to give is the chemotherapy. So chemotherapy for polycythemia may be used either for maintenance or when phlebotomy is not acceptable. In such case you need to give chemotherapy, right? And this particular chemotherapy is a cytoreductive agent. And what is that cytoreductive agent? That is hydroxyurea, right? Hydroxyurea. So this is what is the chemotherapy that you will be giving in scenarios where you cannot do phlebotomy, or in the scenarios where you want to maintain that polycythemia. In such case you need to give this hydroxyurea. So this is about one of the hyperviscosity syndrome, that is your polycythemia rubra vera, right? So what is the very important area where the thrombosis can occur? Even though the thrombosis can occur all over the body, the very important area where thrombosis can occur in polycythemia rubra vera is in the cerebral vasculature, causing ischemic stroke, right? That was our first question. Now you take the another important clinical scenario. Right, this is definitely a very important hematological emergency, and let me see how many of you can answer this. A 22-year-old man is admitted following a severe road traffic accident. He suffered significant blood loss at the scene. He is resuscitated with gelfusion plasma expander and group O negative packed red cells. Intraoperatively, the anesthetist phones you for the advice. What is that? Blood shows hemoglobin of 6.6 milligrams per deciliter, WBC count 11.2, that is 11,200, platelet count of 83,000. Prothrombin time, it is 28 seconds, APTT 72 seconds, fibrinogen level 1.9 grams per liter. What is the most appropriate to use to reduce his bleeding risk? Now if you see carefully, the options are cryoprecipitate, fresh frozen plasma, platelets, prothrombin complex concentrate, vitamin K. Right, so what is the most appropriate to use to reduce his bleeding risk? Right, if you see clearly, what are all the problems here? The platelets are reduced and your prothrombin time is elevated. Normal prothrombin time is how much? Normal prothrombin time is 11 to 13.5 seconds, and here the patient is having 28 seconds. And APTT is also elevated. How much is the normal APTT? That is 25 to 35 seconds. So your APTT is elevated, and as well as the PT is also elevated. Now in this scenario, what is that you need to supplement is, you need to supplement the fresh frozen plasma. Right, fresh frozen plasma. Why? Because both PT and APTT is elevated. That means your extrinsic pathway and as well as intrinsic pathway, both are affected. So in such case you need to give fresh frozen plasma which contains almost all coagulation factors. Almost all coagulation factors. Okay, and this fresh frozen plasma should be given at a dosage of 15 milliunits per kg. That is the dosage of fresh frozen plasma. And what about the other options? Now you take the platelets. You take the platelets. See, when will you give platelets? See, he will definitely require platelets. However, at present, they are greater than recommended threshold. How much is the platelet count? That is 83,000. And how much is the recommended threshold where we give the platelets? You need to give platelets when the platelet count is less than 50 lakhs, sorry, less than 50,000 per cubic millimeter. That is the point when you need to give platelet transfusion. But our patient is having a platelets of 83,000, right? So not to be worried about the platelets here, right? Next, then coming to, now in this scenario, yes, Teja Kumar, I am talking about in this scenario, what is the threshold, right? Road traffic accident, patient had a road traffic accident, okay? Right, it is not like dengue fever. Now coming to the cryoprecipitate. So you take this cryoprecipitate. See, cryoprecipitate is primarily used to replace the fibrinogen. And what should be the fibrinogen levels to give the cryoprecipitate? The fibrinogen should be given, sorry, your cryoprecipitate should be given when the fibrinogen levels are less than 1.5 grams per liter. But our patient is having the fibrinogen of 1.9. So cryoprecipitate is not an emergency now. Then prothrombin complex concentrates. See, prothrombin complex concentrates is used to reverse warfarin overdose. Right, to reverse warfarin overdose, we give this prothrombin complex concentrates. Then you take vitamin K. See, vitamin K definitely can be given, but the problem is vitamin K, it requires 4 to 6 hours for the onset of action. But our patient had a very severe road traffic accident and there is significant blood loss. And you cannot wait for 4 to 6 hours for the onset of action. So here, because both your PT and APTT both are elevated, the emergency treatment is the fresh frozen plasma. And what is the dosage at which the fresh frozen plasma should be given? 15 milliunits per kg, right? So that is about the story of this hematological emergency whenever the patient is having both PT and APTT being elevated. Now, let me discuss about the very, very important hematological emergency, that is disseminated intravascular coagulation. Now, answer this question. The most sensitive test for DIC is serum fibrinogen levels, serum levels of fibrin degradation products, prolonged prothrombin time, and APTT, thrombocytopenia. What is the most sensitive test? Right, very good, Teja Kumar. So the most sensitive test for disseminated intravascular coagulation is the serum levels of the fibrin degradation products. Now, one more question I'll show you. One more question I'll show you, that is, what is the most sensitive test for DIC that predicts the tendency of bleeding? What is the most sensitive test for DIC that predicts the tendency of bleeding? And here, it is not your fibrin degradation products. It is not the correct answer in this place. Most sensitive test for DIC that predicts the tendency of bleeding is the serum fibrinogen levels. Okay, so please remember these two sentences. Right? What is that? Most sensitive test for DIC is elevated fibrin degradation product levels. Most sensitive test for DIC that predicts the tendency of bleeding is the serum fibrinogen levels. So these 2 points are very, very important, right? Now, DIC, what exactly is the problem in DIC? It is a form of consumptive coagulopathy. It is a form of consumptive coagulopathy. So what will happen? Your both intrinsic pathway and extrinsic pathway is utilized for the formation of the clot, and even the platelets are utilized for the formation of the clot. So accordingly, what will be the parameters in patients with the DIC? Right, you see this question. The following is the finding which is seen in patients with disseminated intravascular coagulation. You go through all the options. First option is increased fibrinogen, increased antithrombin 3, increased thrombin antithrombin 3 complexes, increased FDP, decreased prothrombin time, increased antithrombin 3. Third option, increased FDP, prolonged prothrombin time, increased thrombin antithrombin complexes. Fourth option, increased FDP, prolonged PT, reduced platelets. So please tell me, like, what will be the features in the disseminated intravascular coagulation? No. It is not A. See, what will happen to your fibrinogen levels? The fibrinogen levels are utilized. So there will be decreased fibrinogen levels. So A is not the correct answer here. Right? So what did we discuss about your DIC? DIC is what? It is a form of consumptive coagulopathy. And you know, like, what are all the events that will happen in these patients? There will be utilization of both intrinsic and extrinsic mechanism. Right? By utilizing intrinsic and extrinsic mechanism, there will be formation of a clot. That is nothing but a thrombotic phase. Now, in this particular thrombus, it is not only the coagulation factors, there will be also platelets. That means your coagulation factors are reduced, even your platelets are also reduced. Now, this particular clot will undergo clot lysis. That is fibrinolysis. So thereby there will be increase in your fibrin degradation products. So whenever this clot undergoes clot lysis, that will cause increase in the levels of the fibrin degradation products. Okay, and there will be also increase in your plasmin. There will be also decrease in the plasminogen. Right? Okay, so now, yes, the correct statement here is very good. The answer is D here. The answer is D. There will be increase in your fibrin degradation products. There will be prolonged prothrombin time. Why? Because your extrinsic pathway is utilized. And there will be reduced platelets. Why? Because the platelets are utilized for the formation of the clot. Now, the laboratory manifestations in disseminated intravascular coagulation is very, very important. Now, you see this table, which is very, very important for your DIC. Now, please tell me quickly, what will happen to your platelet count? The platelets are utilized for the formation of thrombus. So, the platelet count will be reduced. Then you take prothrombin time. So what will happen to prothrombin time? Your extrinsic pathway, intrinsic pathway, both are utilized. So once the extrinsic pathway is utilized, prothrombin time increases. When intrinsic pathway is utilized, activated partial thromboplastin time is increased. And even your thrombin time is increased because there is decrease in your plasma fibrinogen levels. So the coagulation factors are utilized for the formation of the clot. So fibrinogen level reduces. Then what will happen to plasma factor 5 and as well as factor 7? Both are reduced because all the coagulation factors are reduced, are utilized for the formation of the clot. And this particular clot will undergo clot lysis, resulting in fibrin degradation product, which is nothing but D-dimer. So your fibrin degradation product and as well as D-dimer, both are elevated. So these will be the laboratory manifestations in patients with the DIC. So in patients with DIC, disseminated intravascular coagulation, there will be clot formation in multiple vessels in our body. Now, this particular clot, whenever it is formed within the smaller vasculature, what can happen to your RBC? The RBC can rupture. Right, whenever the clot forms within the smaller vessels, and the RBC, whenever they are passing through smaller vessels containing the clots, the RBC can rupture. And because the RBC ruptures, that will result in microangiopathic hemolytic anemia. So because of this microangiopathic hemolytic anemia, whenever you do a peripheral smear, you will observe the presence of the schistocytes. You will observe the presence of the helmet cells. Right, you will observe the presence of the Burr cells. Okay, and these are all secondary to microangiopathic hemolytic anemia. Now, accordingly, what will be the clinical manifestations in these patients now? Now, you see, what has happened to the platelets? The platelets are reduced. So what will happen to the bleeding risk? There will be increased bleeding risk. There will be increased bleeding risk. So because of this increased bleeding risk, there will be formation of ecchymosis. There will be formation of petechiae. There will be bleeding from the sites of venipuncture. There will be gum bleeding. There will be epistaxis. There will be gastrointestinal hemorrhage. And because of which the patient will land up into a state of shock. Right, because of which the patient will land up into a state of shock. And once the patient develops shock, the individual will develop pre-renal type of acute renal failure. The individual will develop pre-renal type of acute renal failure. Okay, that is one point. That is bleeding all over the body. Next, I said you the clot formation, and this particular clot can occur in multiple vessels in our body, but the place where the clot formation is very common is within the brain, followed by that heart, followed by that lung, followed by that kidney. So these are all the places where the clot formation can occur. Right. Then, yeah, regarding Sandhya, regarding anemia, I will be taking a separate session, right? So there I will discuss the questions related to anemia, right? Now, then how do you treat these patients, right? So now the point is bleeding. Why is that? That is because of decrease in your decrease in the platelets. So you need to give platelet transfusion. When will you give the platelet transfusion? The platelet transfusion should be given when the platelet count is less than 10 to 20,000 cells per microliter. That is the point when you need to give platelet transfusion. And the other point is the plasma fibrinogen levels are reduced. So you need to see that the plasma fibrinogen levels should be more than 150 milligrams per deciliter. Right, the plasma fibrinogen level should be more than 150 milligrams per deciliter. So for that you need to give the cryoprecipitate. For that you need to give cryoprecipitate. And whenever your PT and APTT is elevated, you also need to give fresh frozen plasma. So this will be the treatment in patients with a disseminated intravascular coagulation. Okay, so this completes the discussion of your DIC. So the entire DIC in one particular slide, right? Now we'll move on to the next important hematological emergency next to your disseminated intravascular coagulation, right? You see this question. A previously well 26-year-old woman presents at term after an uneventful pregnancy in the late stages of labor. This is her first pregnancy. Delivery is uneventful. The baby is well but is noted to have widespread petechial rashes. Investigations showed the hemoglobin 16.8 milligrams per deciliter, MCV 90 femtoliters, WBC count 12,000 per cubic millimeter, platelet count, right, is only 70,000 per cubic millimeter, prothrombin time 12, which is normal, APTT 30, which is normal, fibrinogen levels 4, which is normal, and the blood film shows true thrombocytopenia. What is the most likely cause of the low platelets? The options are disseminated intravascular coagulation, immune thrombocytopenic purpura, intrauterine growth retardation, neonatal alloimmune thrombocytopenia. Right. So what do you think is the correct answer here? No. Teja Kumar, it is not your disseminated intravascular coagulation at all. What did I tell you? Just now we have discussed in disseminated intravascular coagulation, prothrombin time is elevated, APTT is elevated, and fibrinogen levels are reduced. If you take our patient, the baby is having everything normal, PT normal, APTT normal, fibrinogen level normal, that will rule out your disseminated intravascular coagulation, and that will also rule out your immune thrombocytopenic purpura as well. Because even in immune thrombocytopenic purpura, the coagulation profile will not be normal. So your ITP is also ruled out, right? And ITP is unlikely. Why? Because there is absence of history of maternal immune thrombocytopenia, right? Absence of maternal immune thrombocytopenia because a previously well 26-year-old woman. So your immune thrombocytopenic purpura is ruled out. Then intrauterine growth retardation is ruled out because the baby is well except for having widespread petechial rash. So what is the answer here? That is neonatal alloimmune thrombocytopenia. Now, what exactly you understand by this word neonatal alloimmune thrombocytopenia? See, when will this occur? This will occur when maternal alloantibodies, right? This will occur when maternal alloantibodies, maternal means the one which is coming from the mother. Maternal alloantibodies, they are formed against, right? These are formed against the fetal platelet antigens which are inherited from the father. Okay, so what do you mean by neonatal alloimmune thrombocytopenia? This occurs when maternal alloantibodies, they are formed against the fetal platelet antigens which are inherited from father. That is what is called neonatal alloimmune thrombocytopenia. Right now, what is the treatment for this? The platelets will recover spontaneously, right? But when the platelet count, if it is less than 10,000 per cubic millimeter, yes, you give platelet transfusion. But if the platelet count is more than 10,000, when there is no bleeding tendencies, the platelet count will recover spontaneously. You don't require to give any platelet transfusion. So here the answer is neonatal alloimmune thrombocytopenia. I hope everyone is clear with this particular question. Yes, everyone has understood this alloimmune thrombocytopenia. This is one of the hematological emergency that can occur within the newborn babies. Right, now let me discuss one more important hematological emergency clinical scenario. Right, you see another clinical scenario, right? Sudden cardiac death following transfusion. So how do you manage now? So you see this clinical scenario. A 36-year-old man receiving a platelet transfusion prior to Hickman line removal following a stem cell transplant for acute myeloid leukemia. What is Hickman line? I'll show you. 10 minutes after transfusion started, he becomes acutely breathless, hypotensive, and febrile. Despite intensive resuscitation, he dies. What is the most likely cause of his death? Bacterial contamination, metabolic induced cardiac arrhythmia, pulmonary embolism, transfusion associated circulatory overload, transfusion of ABO incompatible unit. Yes, what do you think is the correct answer here? Yes, Tejakumar, there is no option of TRALI here. There is no option of TRALI. Transfusion associated acute lung injury, the option is not there. So what do you think is the correct answer? So, right. So the correct answer here is no. It is bacterial contamination. It is not transfusion associated circulatory overload. No, I'll explain to you. Right? Let me explain to you one by one. Now, why am I considering bacterial contamination is, you should not miss this word febrile. You should not miss that word that the patient is febrile. Okay, you should not miss this. Now, you take, many of you are answering D. Transfusion associated circulatory overload is associated with transfusion of large volumes of, right? This will occur whenever the patient is given large volumes relative to the patient, right? Now, there is no particular mention saying that, the history does not give you any point saying that there is high volume transfusion. So your transfusion associated circulatory overload is ruled out. And in patients with your TACO, that is transfusion associated circulatory overload, the patient need not be febrile, right? The patient need not be febrile. So your TACO is ruled out. Now you take the other options. Now, metabolic induced cardiac arrhythmias. See, now there is no particular point saying that the heart rate of the individual is being elevated, and that metabolic induced cardiac arrhythmias are uncommon in case of transfusions. So your B is ruled out. Now you take pulmonary emboli. Pulmonary emboli are not generally associated with fever. The patient is having fever. In pulmonary embolism, you don't have fever. So pulmonary embolism is ruled out. Then coming to ABO incompatibility. See, ABO incompatibility resulting in catastrophic circulatory collapse is most often associated with RBC transfusion, not platelet transfusion. See, whenever you are doing the platelet transfusion, we don't check for ABO compatibility. we don't check for ABO compatibility for platelet transfusion, but for RBC transfusion we check for ABO incompatibility. Okay, so the ABO incompatibility is ruled out. This can happen with RBC transfusion but not platelet transfusion. What is the correct answer here? That is bacterial contamination of the platelets can result in rapid onset of the acute circulatory compromise. Right, what would be the reason is it is thought to occur secondary to exposure to significant bacterial toxin. Right, in this particular platelet you have a significant bacterial toxin, and that particular significant bacterial toxin is the one which is responsible for contamination of the platelet unit, and that is what is causing acute circulatory compromise. So what is one important point telling you it is a bacterial contamination? That is febrile. And what do you think is the type of shock here now? The patient has developed the septic shock and finally patient had expired. Now what do you think is the drug of choice for septic shock? Apart from antibiotics, like what do you think is the drug of choice for the septic shock? So please remember dopamine and as well as dobutamine, right? Dopamine and as well as dobutamine are the drugs of choice for improving cardiac contractility, with dopamine being preferred agents in hypotensive patients. Right, if the patient is hypotensive, definitely dopamine is being preferred because dobutamine will further reduce the blood pressure of the individual by causing peripheral vasodilatation. So whenever the patient is hypotensive, preferable to give dopamine. And when can you give this dobutamine? Dobutamine is used in early goal-directed therapy if there is evidence that tissue hypoperfusion and myocardial dysfunction is related to sepsis. Right, if there is hypoperfusion and myocardial dysfunction related to sepsis, then you can give this particular dobutamine. Okay, otherwise dopamine and dobutamine is considered as the drug of choice for your septic shock next to your antibiotics. Okay, right, so that was about your how to manage the sudden cardiac death following transfusion of the platelets which have been contaminated. Right, next you see another important hematological emergency secondary to neutropenic fever. A 6-year-old patient had severe neutropenia, and how much is that? That is 0.2 into 10 to the power of 9. That means the neutrophil counts are very much reduced. That is less than 2000, lasting for more than 7 days. Following initial treatment for acute myeloid leukemia, which of the following is true? Which of the following is true? Azole prophylaxis against fungal infection with posaconazole is not recommended. Gram-negative sepsis is more common than gram-positive sepsis. Indwelling Hickman lines are more commonly infected with gram-negative organisms than gram-positive ones. Neutropenic fever should be treated empirically prior to receiving the results of blood culture. Quinolone prophylaxis is not recommended to prevent the sepsis. What do you think is the correct statement? So the correct statement here is yes, any one of you? Right, so the correct statement here is no. The answer is D. The answer is D. That is, neutropenic fever should be treated empirically prior to receiving the results of the blood culture. Now, what about the other options? You take the, so what is exactly this? This is a neutropenic fever. Now, what about the azole prophylaxis against fungal infections with posaconazole? It is recommended. The point not recommended is an incorrect statement. Okay, so azole prophylaxis, that is posaconazole prophylaxis, should be given in the patient with neutropenia, in the patients with neutropenia. Next, now you take gram-negative sepsis is more common than gram-positive sepsis is an incorrect statement, right? What is that? Gram-positive infections, right? Gram positive infections are more common than compared to that of gram negative sepsis. Although gram negative infections are more life threatening, but gram positive infections are more common than gram negative infections, even the patient is on any indwelling line. So what is this particular Hickman line? This is what is your Hickman line. Okay, this is what is your the Hickman line. Okay, right? And this is what is your Hickman line. That is nothing but the line which we passed into your the central venous catheter, right? Now in this particular Hickman lines, okay, so this indwelling Hickman lines are more commonly infected with gram positive organism. It is not gram negative, it is with gram positive organism. And what is that gram positive organism? That is Staphylococcus epidermidis. And all these neutropenic sepsis or neutropenic patients, they have to be given empirical antibiotic. And that particular empirical antibiotic that we give is piperacillin plus tazobactam should be given. Right? Piperacillin plus tazobactam should be given. Okay. And quinolone prophylaxis is not recommended to prevent the sepsis is an incorrect statement. Quinolone prophylaxis can be given to prevent the sepsis. Okay. Right. So the correct answer here is the D. Neutropenic fever should be treated empirically prior to receiving the results of blood culture. And what is that antibiotic that we give? Piperacillin plus tazobactam with or without the aminoglycosides. With or without aminoglycosides. Now the last question before winding up the session. So that was the one of, see, neutropenic fever is one of the very, very important emergency. Otherwise the patient will end up in septic shock, right? So you see the question. Yes, Anubhav. See, like in case of septic shock, right, let me tell you what all would be the drug of choice. Dopamine, dobutamine, and as well as the norepinephrine. So all of these can be given, but only point is whenever there is myocardial dysfunction, whenever there is myocardial dysfunction, in order to improve the myocardial contractility and reducing the afterload, the preferable drug is dobutamine, because dobutamine will increase the cardiac contractility and will cause peripheral vasodilatation. So dobutamine will decrease the afterload on the heart. So that is the reason why dobutamine is being preferred whenever there is myocardial dysfunction. But what will your norepinephrine do? Norepinephrine will increase the afterload on the heart. So whenever there is a myocardial dysfunction causing cardiogenic shock or septic shock, don't give this norepinephrine. The preferable is dobutamine, because dobutamine will cause peripheral vasodilatation, thereby decreasing the afterload on the heart. Yes, Anubhav, is that clear now? Okay, now this is the last question. A patient receives a blood transfusion and has developed complications. Which of the following combinations will result in least insult to the patient? Group AB red cells into group O adult, group B red cells into a group A adult, group B red cells into a group A neonate, group O fresh frozen plasma into group A adult, group O FFP into a group B adult. Tell me which of the following combination will result in least insult to the patient. Right. So let me just tell you. You take group O. These patients, they will have the antibodies. What are those antibodies? That is anti-A and as well as anti-B. So this particular anti-A and anti-B, they will react with recipient's red blood expressing A or B antigens. So now definitely this, and even you take fresh frozen plasma. Fresh frozen plasma also contain this particular anti-A and anti-B. So that is the reason why your group O FFP giving into group A adult or group B adult, that will definitely cause an insult, because you take group A adult will have A antigen, right? That so this anti-A which is present in group O can cross react with the A antigen, and same story is even in your group B adult also. Now you take group AB red cell. Group AB red cell, you have A antigen and as well as B antigen, and you don't have the antibodies. But the problem is the group O adult who is receiving that group AB will contain anti-A and as well as anti-B, which will cross react with group A antigen and as well as group B antigen. Okay, so this is also this patient also will definitely have the insult. Now group B red cells into group A, never. That will cause immediate anaphylactic shock. Now group B red cells can be given into group A neonate, that will have less insult. Now the question is why? Because you take this neonate immune system does not produce antibodies, right? Neonate immune system does not produce the antibodies when exposed to exogenous antigens, and so neonates tolerate ABO incompatibility better than adults. Okay, neonates, they tolerate better than compared to that of adults about the ABO incompatibility. So what is the correct answer here? The correct answer is group B red cells into group A neonate, they will have less insult. I hope everyone has understood this question. Right. So these are some of the quick important hematological emergencies, right? So with this, I'll wind up this particular session and then see you in the subsequent sessions, right? So if you want this particular PDF, you can join my Telegram channel, that is Medicine Made Easy by Rajesh Gubba, wherein I'll send this particular PPT, or I'll be also sending this particular PPT in the DBMCI Telegram channel as well. Okay, so thank you very much. See you in the upcoming sessions.